session for November. My name is Ken Lamoureux. I'm part of the Info Series subcommittee that plans all of these events, and I'll be the facilitator for today. And welcome to our session that's called Wraparound Support for Pregnant Women and New Mothers Who Use Substances. Before we get started, I just wanted to acknowledge that the Manitoba FASD Coalition gathers and works on the treaty land of Manitoba, the traditional territories of the Anishinaabe, Cree, Ojai Cree, Assiniboine, Dakota, and Dene peoples, and the homeland of the Métis Nation. And before we get started, I just wanted to provide a little bit of housekeeping. There's a lot of us registered and attending today's event. So while our presenters are sharing their slides and sharing their presentation, we ask that everybody turn off their video and their audio, just so that we ensure we have a good connection and there's no delays or lags during our presentation. As our presenters are sharing the information, if you have any thoughts or questions, feel free to include them in the chat option. The subcommittee will be looking at the chat throughout the presentation and keeping track of any questions that people have, because at the end of the presentation, we will have time for question and answers with our presenters. So feel free to add any questions or thoughts in there and we'll keep track of them for you. At this point, I will introduce our three speakers for today. The first presenter I'd like to introduce is Nancy Poole. Nancy Poole is the prevention lead for the CanFASD Research Network, guiding a pan-Canadian network of researchers, service providers, policy analysts, and community-based advocates working on FASD prevention. She is the director of the Centre of Excellence for Women's Health, a research and knowledge exchange center hosted by BC Women's Hospital and Health Centre in Vancouver. Nancy has a doctorate in education and recently was awarded an honorary doctorate by the Justice Institute of BC in recognition of her contributions to women's health, including trauma-informed practice and the treatment of substance use and addiction. Another presenter that we're fortunate to hear from today is Deborah Rutman. Deborah Rutman is a co-founder and principal with Nota Bene Counseling Group. She has conducted numerous FASD-related research and program evaluation study, and also has undertaken studies relating to young people in and from foster care. Along with colleagues Carol Huberstay, Marilyn Van Bibber, and Nancy Poole, Deb is project lead of the National Co-Creating Evidence Evaluation Study. Other recent projects include creating evaluation maps for FASD prevention and support programs, promising approaches in working with women with FASD and substance use issues, and program evaluations of Her Way Home, the BC Key Worker Program, and the Youth Outreach Program. And our third presenter is Hayley Thomas. Hayley Thomas is a First Nations woman of mixed heritage from Winnipeg, Manitoba. She is currently the program manager of the Mothering Project at Mount Carmel Clinic in the heart of the North End in Winnipeg. Hayley has a bachelor's of social work degree from the University of Manitoba. She has a significant background in trauma-informed frontline social work, including many years in the child welfare system. When not at work, Hayley enjoys traditional beading practices, fitness, and walking her big dog, who thinks he's a small dog. And with that, I will turn it over to our presenters to start our session today. Thank you.
Thank you, Ken. I think I'm up first. So, hello, everybody. It's a real honor to be asked to share with you today about the Co-Creating Evidence Project. And I'm just going to pop on the slides on my screen, on the screen. And let me also go back from the very beginning of the slides. Set. Here we go. So just to give a little bit of an overview, I believe that how we're organizing our time today is that I'm going to be talking first, and then Hayley will be going next, and then Nancy will be doing the cleanup and the final presentation before we get into questions and answers. And I also thank you, Ken, again for your good opening. I wanted to start by saying that I am an appreciative and a very grateful guest living in and calling in today from the traditional, ancestral and unceded territories of the Lekwungen-speaking peoples, and in particular the Songhees and Esquimalt and WSÁNEĆ nations. And I'm also speaking on behalf of our project lead group for the Co-Creating Evidence Project. Joining with me on the project are Carol Hubbersty and Marilyn Van Bibber, also from Note Bene Consulting Group, and Nancy Poole from the Center of Excellence for Women's Health. So what is the Co-Creating Evidence Project? We're currently in phase 2, but the bulk of it has been a multi-site evaluation involving 8 programs, 8 wraparound programs across Canada. The project was funded by the Public Health Agency of Canada. Again, we're just really appreciative of the support that they've provided. Let me move to the next slide. So what were we attempting to do with this project? The Co-Creating Evidence Project was the first of its kind in Canada, national evaluation involving 8 different programs that were all serving women or pregnant people, pregnant and parenting people at high risk of having an infant with FASD or prenatal substance exposure. The project had 3 overall objectives. First was to have an opportunity to bring together many of Canada's holistic FASD prevention programs to come together and share promising practices. Whoops, let's go back here. And to do that in an ongoing way, which we did face-to-face pre-COVID in the early years of the project, and then approximately every 2 months by virtual gatherings that allowed us to talk about current issues, the evaluation underway, some of our findings, and then our knowledge translation. The project was an evaluation to evaluate the effectiveness of multi-service programs that were serving women with substance use and complex issues, and to identify the characteristics that make these programs successful. So who was involved? You see here on this slide a map of Canada in which we show where all the 8 programs were situated. And again, I want to emphasize, this is not an evaluation of one program that's implemented across the country. These are 8 different programs that all arose and have been operating in keeping with and aligned with local needs and priorities and resources. So there were 3 programs in British Columbia. In Victoria, there's Her Way Home. In Vancouver, there's She Way. In Surrey, there's Maxine Wright Community Health Center. In Edmonton is the Her Pregnancy Program. In Regina, there's Raising Hope. And that's the only program that participated in the project that was actually a residential-based wraparound program that involved services in coming on site as well as assisting women to go into the community to access services. Winnipeg is the Mothering Project, which Hayley will be talking about in more detail. Toronto was Breaking the Cycle, and in New Glasgow, Nova Scotia was Baby Basics at Kids First. These 8 programs represent essentially 2 generations of wraparound holistic programs. She Way and Breaking the Cycle were in the first generation. They've been operating for more than 25 years, starting up in the mid-1990s. And the second generation are programs that started in the mid to later on in the 2000s. Okay. Now, in terms of doing the evaluation, before I actually get to the slide, I just wanted to say a little bit about, just a minute about our methodology. We had the privilege, again, pre-COVID, of being able to do face-to-face interviews with the program's clients, staff, and program partners. So our program team went to each of the programs twice, once in 2018, once in 2019. And over the course of those visits, we actually did a total of more than 400 interviews, and approximately 250 of them were with clients themselves. In addition, the programs each provided us as the project team with every 3 months snapshots of clients' outcomes in relation to housing, to substance use, to perinatal outcomes, and housing, substance use, perinatal outcomes, and child welfare, sorry, and also programming activities. So it was quite, you know, an extensive, comprehensive, multi-method approach. So what I want to talk about now is a little bit about the programs themselves. We talk about these as wraparound programs, but what are wraparound programs? We created this visual to describe how the programs support women in so many, and women and their children in so many different ways. Women are coming to these programs in their pregnancy or postnatally, and typically are not looking for just one single thing. They're typically have a number of things that they're working on, anything from housing to substance use, intimate partner violence, basic needs, issues related to child welfare. And the programs are supporting their clients and families in so many different ways. This visual provides a sense of overall how the 8 programs support women in such different ways. No one program does it all. And we never are meaning to suggest that any one program should be doing all of this. Again, this is a synthesis of what we saw overall and how the clients experienced the programs. So the small little dots that admittedly are hard to see in this visual are telling us from clients' perspective the types of actual services or activities or supports that they were able to access through their involvement with the programs overall. One of the things that we did early on with the programs in a face-to-face gathering that we held in the very beginning of the program is we created what's called a theory of change. And a theory of change is a statement that says what in an evaluation we expect to see. So when programs are providing a certain set of activities and services, and they're doing so in a certain approach, using certain approaches or practices, then these are the kinds of outcomes that we are hoping or expecting to see. So in coming together face to face, we were able to establish and identify this set, this collection of common approaches that each of the programs, even though they were operating and providing different types of services and doing things in different ways, they nevertheless had this common set of approaches. They were all relationship-based. They all used a harm reduction approach. They were all trauma-informed. They were culturally grounded, as well as being culturally safe. They approached their working with clients in an interdisciplinary way, and some in particular used a developmental lens. So they were working with the pregnant person, the mother, the pregnant woman, as well as working with the child simultaneously. And so the integrated care was integrated in that way. They also used an approach of kindness and compassion. And that's something that the literature doesn't always lift out. And Hayley, I will have to actually hold my hand up to you. I think that we heard that kindness and compassion and the importance of it as being a key foundational principle from the Mothering Project, although it was one that was absolutely endorsed by all. And the programs were also women-centered. At the core of that was the notion of being non-judgmental, safe, and strengths-based, and that we heard from the women and how they experienced the programs. I'm going to take a moment to talk a little bit about the wraparound services from an Indigenous cultural lens. I mentioned that cultural safety was, and being cultural grounded was an important foundational approach and principle. Overall, the majority of women who were attending these programs overall were Indigenous. that, you know, percentage-wise, that was 55% of the clients of overall, but it really was a range from in the high 90s to programs such as the Mothering Project, to 1% at the program that was in New Glasgow, Nova Scotia. But nevertheless, 4 of the programs really had a very strong focus on integrating Indigenous cultural activities and ceremony within their activities. And through this became both a healing resource for both the women and for staff who were dealing with trauma issues and providing frontline services. One of the things that was really important was seeing how culturally grounded approaches blended and were woven together with harm reduction and a low barrier approach in which women were welcome, even though they may have been using substances themselves. We've identified and lifted out the variety of different types of Indigenous cultural programming that collectively the programs offered. And so this slide speaks to that. And in the center here, we have some quotes from women and from staff about what that felt like, serving the foods, traditional foods such as bannock and soup and salmon and rice during the hot lunch program, bringing families together, babies together to have a baby welcoming ceremony. We really see that these wraparound holistic programs are so aligned with traditional Indigenous programming and approaches. They're strength-based. They come from a position of recognizing and honoring women's tenacity and resilience, and therefore they really are an act of reconciliation, where the clients and staff are experiencing the healing resources that are offered through Indigenous cultural approaches to well-being and healing. I mentioned that the programs, that women come to the programs for a variety of reasons, and so this slide just identifies the top themes that emerged in our conversations with the clients about why they come to these wraparound programs. It's not one simple reason. It's not just about getting help for their substance use or trauma. But these top themes here in that top bubble in the sort of orange gold really align so nicely with when we talk to women about what was the most significant change since participating in their program. So the top themes were for women that they were able to quit or reduce or have safer substance use. They had strengthened mother-child connection or were keeping or regaining their children in their care. Children who had been removed were coming back into their care through the support of the program. They were experiencing increased support. They were able to access safer and improved housing, and they were able to connect to community, to family, to peers, and to culture. We talk, and I think Nancy will be talking about this more, and Hayley likely will be as well. So important that when we asked clients through the questionnaire and through the interviews about their experiences in the program, what came out so strongly was their sense of feeling safe. They trusted staff. They feel as though staff are going to do what they say they're going to do when they say they're going to do it. And their needs have been met. And I know that one of the programs, when they've done presentations to their own community about the findings from this study, they say for them, that's what so matters. That's that experience of ensuring that the clients feel safe there. Some spoke about it being a sanctuary, a place where within their community, they could come and just know that they could be, and it would be okay, that sense of community. So just in wrapping up, what did we learn in terms of practice implications? So important that these programs offer essentially a one-stop approach, that women are not needing to go to a variety of places in the community. If they do go to places in the community through the support of the program, they are supported by staff in accessing the services. The Indigenous cultural connection and reconnection that is provided or offered through the programs is extremely important. And we heard that from staff, from partners, and from the clients themselves. These programs could not be what they are without the exceptionally knowledgeable and empathetic program staff. And staff are knowledgeable and compassionate and caring in so many different ways. So many different areas of ways, from child welfare to accessing basic needs, to the legal system, and to a variety of different health-related issues. The programs all had a well-conceptualized, evidence-based theoretical foundation, which we talked about before, and the importance of that, and the programs adhering to that. So putting into practice every day those theoretical approaches. Didn't really have an opportunity to talk about, but these programs could not operate without the partnership relationships they've developed, both with the health services in their regions, but also through the community-based and child welfare organizations that they're working closely with. And also, so many of the programs have opportunities for peer support, either through staff who have been hired as peer outreach support workers, but also through the peer relationships that are developing within the friendships and the relationships amongst clients and former clients. And practice and policy implications. These programs have been operating, but not without their own challenges. Funding is always an issue. And so it is absolutely essential that these programs have access to stable funding to enable adequate and stable staffing. Many of these programs continue to struggle with with funding, and it's just so essential that the base foundation of funding is in place. Another issue is working to address the increasing complexity and intensity of women's needs. There's an increasing complexity and harm associated with the substance use, the substances that currently exist, and we hear about that in our ongoing community of practice meetings with the programs that we're still doing through the project. Working collaboratively across sectors is always a challenge. It's always something that we have to keep working at, making sure that the partners are using and able to kind of use the lens of the same type of foundational approaches that the programs are using, in particular harm reduction, trauma-informed, and cultural safety. The programs are still challenged to offer a linked program for women who need longer support, longer term supports than what these programs are able to offer, or those who continue to struggle with addictions. And lastly, housing is perennially a significant gap. It was in all the communities that these programs operated, as well as programming for women who have had their children removed. Just to wrap up, we have a report that is available through a website, which is on the next page, and also a number of 2-pagers that we've been able to summarize our findings through the project. This is the list of 2-pagers, and here is the final slide that has both contact information for our group, as well as for how to access the report and the 2-pagers that have come out of phase 1 of co-creating. And with that, over to you, Hayley.
Everybody can see my slide? Perfect. Okay, so yeah, as Deborah had kind of mentioned, so I'm going to be sharing some of the key findings that Mothering Project kind of came away with in terms of being involved with the Co-Creating Evidence Project. I'm going to touch on some of the stuff that was found in terms of what's really important when delivering care to mothers who are experiencing chaotic substance and alcohol use, and just supporting them as much as possible to make sure that they are successful in whatever way they might define success. So I'm just going to go through, I have the key talking points here in terms of what we found were really important when in delivering care throughout the study. And then I'm going to detail some takeaways in terms of how we at the Mothering Project could deliver these things. So one of the things that was found that is really important when delivering this care is wraparound services, as Deborah had mentioned. So we do find that that's very important because for a number of reasons. So as Deborah had mentioned, a lot of ladies did mention throughout this study that for them, the Mothering Project is a very safe place. And so the thing is, unfortunately, especially for mothers, there's a lot of stigma, as we know, around mothers who are using substances, and they do not feel safe in a lot of other places. This includes healthcare, child welfare services, wherever else. A lot of the time, there's a very big fear that their use is going to be reported to child welfare and their children will be apprehended. So because we know that a lot of our ladies are not going to access a lot of these services, if it's not something we offer, we do as much of that as possible. We are very fortunate that we're in a healthcare clinic, which means that we are able to collaborate with doctors and nurses to provide all that different care. We provide opiate antagonist therapy, we provide STI care, we provide wound care, we provide family doctors, we have a midwifery team here as well with a OB-GYN on staff. So we're able to link our ladies to all those different things. Even just on our own immediate Mothering Project team, we have all of our outreach workers, as well as 2 community health facilitators who lead their teams of outreach workers. But then we are also very fortunate to we have an early childhood educator who works we actually also have a daycare on site where our ladies are able to access childcare. We have an early childhood educator all to ourselves who is very well versed in children who have prenatal drug and alcohol exposure. And she works specifically with our children, which is really big, again, because a lot of our ladies do not trust other childcare providers. So our ECE is able to make those connections with our ladies and give them that respite that they need when they are parenting. We have an addiction specialist on our team whose name is Sarah. Sarah is able to provide addiction counseling, as well as she is our liaison between detox, treatment services, and the like. We also have an on-site clinical social worker who is a master's level therapy certified social worker. She's able to provide therapy and counseling to our ladies. She specializes in CBT and DBT techniques, which is really important for a lot of our ladies who have experienced trauma, which I will also touch on further down a little bit. And then we also have a child and family services liaison social worker. And so her name is Danielle, and Danielle works for us. She does not work for CFS, which can be confusing for people. However, she's that link, because as we know, a lot of ladies who are mothers who are suffering or struggling with substance use are very weary of dealing with CFS. It's very scary. And so Danielle really works from a very gentle trauma-informed perspective, and she's that link between CFS. So if ladies are needing meetings, are needing to talk to their workers, are wanting to get visits with their kids who are not in their care, Danielle is able to facilitate those things. So we are also able to provide things like food, transportation. We get donations, or we can provide clothing. Sometimes we have diapers, wipes, all those formula, all those kind of things. So we try to be a one-stop shop as much as possible, just to make sure that moms are as supported as possible. The next point that we had found through co-creating evidence that supports our model of care is, again, as was mentioned, the importance of culturally grounded care. So I know Deborah did mention that a few of the programs have a very high percentage of Indigenous participants, and that does include us. We actually, 98% of our clients are Indigenous. And it has been shared to us by them that it's really important that that's something that we're touching on. And so we really believe in grounding all of our approaches and all of our care in an Indigenous way. We actually do have a name that was gifted to us by the elders, which is Manito Iklwe Kagiikwe, which means she walks together. And so we are able to do that in a number of ways. We provide ceremony to our ladies. We have elders on staff that we work with, and we consult them in everything that we do, basically. We also have elders and medicine people that are available to our ladies to access as needed. A lot of our ladies identify that when they're trying to work on staying sober or reducing use, cultural interventions are very important to them in a way that a traditional healthcare or 12-step approach to treatment is not always enough for our ladies. So we try to be really conscious of that, and we find that it makes a very big difference in care. The next point that was touched on in co-creating evidence as well, that is a big part of our program and our success, is the peer support mentorship piece. So we're very fortunate that we have quite a few ladies in our program. We've been here since 2009. So we've been around for 12 years, which means we have quite a few ladies who are quite a bit further along in their journey. And as such, they are able to provide a lot of support and care to some of the ladies who are a little bit newer to their journey or newer moms. So we really see a lot of our ladies wrapping around each other as well and able to provide just that experiential piece that's really important, where ladies feel supported. They know that they're not alone. We try as much to involve our clients in leading things as much as possible. They lead groups, they volunteer in the program. There's all those different pieces. And as we all know, it's really important for people to feel like they belong to something and like they're important. And a lot of our ladies are able to get that from, as they get further along in their journey, they're able to participate more in leadership roles in our program, which makes a very big difference. The next point that was touched on in the study that we also believe in is engaging clients over time. So as anybody with any kind of like psych, social work, research background knows, a big part that's integral to success is time taken to build relationships, that relationship building piece. And it doesn't happen overnight. So we really don't rush things with our ladies. We are very unique in terms of a lot of programs do have a time limit on how long that they're able to work with people, especially here in Winnipeg. We find there's a lot of barriers in terms of a lot of programs have a cap of 12 months, 2 years, things like that. And as we know, when we're dealing with such complex issues as we are, that's just not enough time. A lot of ladies at that point, they're just starting to feel comfortable, kind of like really digging into things. And then all of a sudden they get cut off from service. So we don't do that. Technically in our mandate, ladies can work with us to up to 5 years after they have entered the program. However, we have never cut somebody off from care. We kind of say around here, once you're ours forever. So as long as a lady is identifying that they're needing care and needing support, we will always be here for them. We also do not have a limit. So not all of our clients have a direct outreach worker, but we do base it on need. And we do not put time limits on that. So as long as a lady is needing to work on her stuff, we are going to be there for her. Especially find a lot of our ladies have multiple children. And so we always make sure that we're available there throughout those different pregnancies and motherhood experiences. The next piece that's very important, that was a big part of the study, I know, is trauma-informed care. So yeah, we believe very strongly in trauma-informed care. As I mentioned, we have a number of different pieces to our program. They're all informed by trauma. So our clinical social worker plays a really big piece in that. She does a lot of the trauma care with our ladies. As I mentioned, she does group, she does therapy. She also consults with all of our different people. So our addictions worker, our CFS liaison, our support workers, to really just make sure that we're understanding the role that trauma plays in things, especially with a lot of our ladies. As we know, trauma plays often a very big role in substance and alcohol use. And a lot of our ladies who have been involved in these different systems for a very long time and who have had multiple substance affected pregnancies have experienced a lot of trauma in a lot of different ways. So we try to be really conscious of that. And in our approach to how we're working with ladies, as well as our advocacy, we're doing a lot of advocacy in like hospitals, healthcare, child welfare, in those different pieces, just to make sure that ladies' trauma is being recognized and that they're being worked with in a good way. Our next piece is the harm reduction approach. So, and again, I know this was touched on in the study, and this was a big takeaway that we found in terms of what's really important in helping our ladies find success. So we are very unique in terms of a lot of programs do require sobriety. That's at least in Winnipeg, we find this to be a big barrier. A lot of our ladies are accessing programs, they're relapsing, and then they're getting kicked out. And that does not help. So we are very big on, we do not require sobriety. We believe that what you are doing for a reason. However, we do encourage at all times harm reduction. So we really work with our ladies on identifying their goals, identifying on what they want for their pregnancies, for their parenting. And then we try to just bring that, like practice harm reduction approaches as much as possible to make sure that they are safe, that their baby is safe. So as I mentioned, we are very fortunate in terms of we are connected to midwifery. So our midwives are very helpful are very useful in helping us with that as well. A lot of the times we're collaborating with them. They're helping our ladies identify ways that they can use in a healthier, safer way in order to make sure that their pregnancies are as healthy and successful as possible. And then last but not least, one of the key findings that we had come away with in terms of how we practice and what makes our program successful in supporting our ladies was listening to what our women need. So we are very big on nothing about you without you. We involve our ladies in everything, every step of the way. Traditionally, we had a women's advisory council, which was a panel of some of our women who had been around since the very beginning. And they would meet monthly and we would discuss really what they wanted to see from the program, what they felt they needed, and then we would implement that. So that was put on hold during COVID. And I've been with the program for 1.5 years, so I was not here when that was happening. But in the new year, I am going to be reinstituting. We're actually not going to be doing that anymore. What we're going to be doing is a monthly open house, where I'm going to be having meetings because traditionally it was just a panel of a select few women in the program, whereas I would like to open it up so that anybody in our program, any client who wants to be involved is going to be able to attend these open houses and give us their suggestions. However, we already work in a much more casual way in terms of our ladies are always telling us what they want to see, what would be useful to them. And as long as it's within our ability, we're always implementing that. So a good example of that is our different group programming. Our ladies are always telling us, like, I'd like to do a drum group. I would like to do seeking safety, trauma training, stuff like that. And then again, as long as we have the capacity and the means, we're always putting that in. That even comes down to the way that we designed our space. So our entire space here was renovated a few years ago, and it was actually our ladies that were consulted in terms of what they'd like to see, what they wanted it to look like. And again, that trauma-informed piece, even down to like we are right beside the daycare. We made sure that our entire wall is windows, as is the wall of the daycare's windows. So that if ladies are in here getting care from us, they're also able to actually see their children over in the daycare. And that really, was I muted for a reason? Oh, okay. Yeah, so that's pretty much it. Those were some of our findings from co-creating evidence, which we were very fortunate to be a part of. And we were really grateful that it really just affirmed a lot of the things that we know, and it helped give us just that really deeper understanding of how the things that we do are very useful for our ladies and their children and their families. Thank you.
It's so great, Hayley, to hear of your work. I always enjoy hearing the story of the Mothering Project and how well what you talked about fit into the findings from the Co-Creating Evidence Project overall. So neat. Thank you. I'm just going to add a few more things on the end related to this project. That was actually about mothering and opioids, but Melanie and Ken and others really saw some of the linkages of the work around this project that really is very similar for alcohol and those who are working on preventing FASD, or working with women who are using, opioids as well as alcohol. So the project was really a lot about this concept of stigma that both Hayley and Deborah mentioned, and how critical it is for us as we're designing programs about FASD prevention and support of women and mothers who use substances, is to really be thinking about how stigma affects their ability to connect to services, and how important it is for us to really think through how we can design and offer services in a way that takes stigma and trauma and all the other issues women are facing into account by working collaboratively ourselves. Just want to mention this work was funded by Health Canada, although the views are not necessarily those of Health Canada. And what a really great project team, lots of partners, including the Fasd Research Network and the Prairie Child Welfare Consortium. Lots of folks from child welfare side of things and the addiction side of things, the research, the practice, the lived experience, were all mixed in the group. And here's just a quick picture of us at one of our meetings to just give you a sense of how wonderful it was in those days to be able to come together to do a project face to face. We did a literature review, and we really thought through the work of stigma and the barriers facing pregnant women and mothers who come in contact with the child welfare system and who are substance users. And we drew on this particular framework developed by Dr. Tam and others at the Public Health Agency of Canada, about how there are many levels of stigma that operate and how we can really get thoughtful about addressing them in a really pragmatic way. So I really encourage you, if you haven't read this report or even just the infographic here, I think it's really helpful. We put together a toolkit with 15 sort of tools and self-reflection guides and fact sheets and discussion starters for thinking about you as people designing programs who could really benefit from these kinds of tools. And the first, one piece of it is really about this idea that Hayley and Deborah have both spoken about, is how important it is to center women's needs and perspectives, and to think about, designing things from women's needs and voices up. And there's one tool in the kit that has some great things that some of the women at Her Way Home in Victoria talked about to us, about how workers can show compassion and be supportive and to listen and be educated, and to recognize that just because you may still be using doesn't necessarily make you a bad mother, and that there are many paths, and they really want workers to get behind them and not judge, but instead care. So many great ideas that they generated. We also included mention of the great work of the Mothering Project through, suggesting that people can really benefit from hearing some of the digital narratives that the Mothering Project have on their site, of really thinking through what that means. Others that I've worked with have also talked about doing equity walks that are a bit like what you said, Hayley, about doing the whole group coming and giving advice, of actually walking through the service and looking at the environment, talking to the different workers about what is helpful, or what they experienced as they went through the program, to think through where there may be points of improving practice. The second level of that we talked about in this toolkit is about practitioners' work, about the work, service providers can do in thinking through their own attitudes. And we created this kind of self-assessment tool that a lot of services have said have been really helpful as they hire people or they involve and they talk about it in staff meetings to really help people get to that place of, how can we get rid of our stigmatizing attitudes and our judgments and our biases to really get behind what women need from us. And another piece that's kind of interesting in the toolkit is this one about how coworkers can help their others who work in the service address their stigmatizing attitudes. And they give sort of words that you can use when you hear someone being judgmental or whatever, that might be useful in challenging a coworker on these issues. Like, I wonder what might have happened to the woman if this is a choice she made versus a circumstance that she's facing. And or I've heard other things that have made me think about mothers a bit differently, etc. So a great tool originally developed by Betty Pogue and Dr. Lenora Marcellus, really hopefully helpful. But the final level is really this one that Deborah alluded to around the partnerships part of it, etc. Is how do we effectively work across systems and think about what is it to have relationships with other services and systems of care? What are the opportunities if we can't co-locate to actually learn and train together and enhance our relationships? And we particularly in this study, we're really thinking about that child welfare and substance use service collaboration piece. And on this image from the toolkit, you can see, we thought about what are some of the things that substance use service workers really need to be doing with women, and what are some of the things that are the mandate of child welfare to be doing with children and mothers, and then what are some of the things in the center that we both have as things to be working on. And as Deborah mentioned, that with that theory of change and those foundational philosophies, to be really thinking about, we do share these foundational approaches like mother-child togetherness and involvement of mothers and harm reduction and trauma and violence informed and holistic and culturally safe. And really important for us to be moving towards this place of being more optimistic about what mothers can achieve and more appreciative of what they've been able to do so far, and to be really thinking about how we can really stay connected and support their getting the services that they so richly deserve. So this was a big piece, I think, and really invites us a lot more to think about how collaboration can work when you can map this kind of idea about, yes, we have different mandates, yes, we have shared things we do, and yes, we have foundational approaches we can all be working from. And then we took it to the final level of the policy folks, the government level and others, to really be thinking about what are the policy values that need to be in place that are supporting mothers and children. And we came up with this, idea about these 4 policy values that really needed to be thought more thoroughly about by the policy level folks. Are your policies developed with an input from a wide range of women and their partners and families and communities, those who have lived experiences? So how are people who the policy affects involved in the thinking through of what kind of policy is needed. And, you know, how can policymakers really think about the other systems and services that could be actively linked together to support mothers? So there's not that thing that Hayley mentioned of some services dumping people out when they relapse, as opposed to thinking about, we have a shared need to help people get care. And I know you've got a new ministry about that of addictions, or I forget the name of it, in Manitoba now, that I think can be a big part of thinking through how that can happen. And we also have one here in BC that is working to think about government-wide support for substance use and mental health concerns, not just one ministry thinking about what their responsibilities are. And also thinking a bit about this idea that both Deborah and Hayley mentioned as well, this idea of complexity and how women's concerns and society's concerns are so much more complex now, and that we need to be thinking about how we are integrating harm-reducing, culturally safe, strengths-based, trauma-informed approaches. And that requires us to think more about the complexity of women's lives than some of the policies in the past were, which if you were like, you use substances, you lose your kids, you know, that really we need to get a lot to an entirely different place now. And finally, thinking about the policy value of being respectful of women and optimistic and compassionate. And is there an understanding that women want the best for their children and can change, like the women noted in the 10 things that they want us to know? So really, I think takes us to an entirely different place than, you know, forcing women to change. I think it's a lot about forcing us as service providers, policy folks and researchers to think about what's our role in making change. And just wanted to mention this guide that I worked on with the Ministry for Children and Family Development here in BC that kind of gives a view of this. This is one of the pages of the guide that talks about NCFD being about supporting children and youth, applying gender and cultural and developmental lenses, involving families and peers, thinking about worker wellness and safety, thinking about the culture and the policies of the agencies that are delivering services, and really thinking about what is the work of leadership to make a trauma-informed approach throughout the whole ministry. Now, they have not achieved this yet, but I'm just saying it's an aspirational piece that I think really takes trauma-informed to the system level and the agency level, not only in our interactions with clients. So my last slide here is just about the fact that we are, and you are, drawing on many wise practices when we're working with women and having conversations about alcohol and other substance use. And many of you may remember this, you know, Doorways to Conversation guide that we did in collaboration with you in Manitoba, as well as all the other provinces and territories across Canada, really noting how you're bringing these kinds of great approaches into your work that are strengths-based and harm reduction oriented, that involve motivational interviewing, that are trauma-informed and culturally safe, and focus on Indigenous women's wellness and taking into account the determinants of health, etc. But I think there's so much more we can do to build on this foundation by doing some of the things that that toolkit talks about centering women, addressing stigma, building upon our skills and strengths as providers, collaborating across systems, and really thinking about shifting our policy approaches to be much more supportive. So that's my piece to add to the three-part presentation.
Well, thank you, Deborah, Hayley, and Nancy for sharing with us today. It was a really great presentation. I appreciate hearing just what's happening across Canada. I always love hearing about the Mothering Project here in Manitoba. It's a great resource that we have. And Nancy, I appreciate at the end, they're just talking about how policy systems and services, how we can change, right? We need to think about that as opposed to how can the program participants change. So I really appreciate that. Thank you so much. We'll open it up to questions. So one question that was asked was about your slides. I'm wondering if you'd be willing to share your slides with attendees here today.
Yes.
Yes, absolutely.
Okay, thank you. So other than that, I didn't see any other questions pop up in the chat. So I'll just open it up. Were there any questions from anyone that is listening today?
I wish we could have one of these in our community.
What's that?
It'd be awesome.
What's that? Oh, sorry.
And sorry, Shelley, which community are you in?
I'm from Creighton, Saskatchewan.
Oh,
Like we're on the border of Flin Flon, Manitoba. And I work for Kids First, and our program only goes up to age 3. So, but we find that, like the lady said earlier, families still, all their problems aren't solved by the time their child is age 3. Or if they're a high-risk family, they're not necessarily putting their children in the pre-K programs that could also support them, right? So, yeah, no, it sounds good.
no, thank you. Marlene, I see your hand is up.
Yeah. Hello, everyone. I am Marlene Bonicastle. I am a professor at the Faculty of Social Work, and I've been working with a project with Brenda Elias and about the Dignity Project. Anyway, thank you very much for the presentation. It was excellent presentation. I really enjoy a lot. Interesting that I think was Hayley, but also I have heard many times about trust, the lack of trust of lived experienced people, including women and people with FASD, lack of trust on services. Can you elaborate a little more, or if you have done any work in that part? Because I think and I have here in the research we are doing about this is one, it is coming regularly. And I know services are working very hard on this. And I think my question is more what you think we need to work more. Because I honestly am very impressed about the work that people working in FASD are doing. But still people continue to say about that lack of trust on services. And I don't know if this is in general, services at all, or I don't know. It's just if you can comment something else about that.
Sorry, was that a question for me?
I
I don't fully understand the question. You're muted.
You mentioned at some time that some people mention about the lack of trust on services, but I have heard that word, that expression on people participating in my research. It's not like new for me, but I myself, I am questioning what needs to be done, or I don't know, just I think it's, but I recognize the hard work that people are doing on this. So my question is, what is missing maybe in to build a stronger trust or addressing that comment? Yeah.
Okay, yeah, thank you for clarifying. Yeah, I can answer that. So what we see, like a lot of the issues with trust just seem to be around, like I had mentioned, ladies just not feeling like people are being empathetic and understanding. Just a lot of, so like non-judgmental care is really important. And I think a lot of what would be really important is just working with the ladies instead of right away getting external services involved. So like for us, what that really kind of means in a practical way is like I said, a lot of our ladies, that trust is difficult because they don't trust. They're scared that these other places are just going to call CFS on them right away, are going to call Children's Protective Services. And so, whereas like they really trust us, whereas like we're still mandatory reporters. Like if I believe a child is at imminent risk of harm, I do have to call CFS. However, we will always work. So we don't do anything without telling the women. And I think that's really important, is a lot of women just don't trust that places aren't going to do stuff behind their back. So we straight up tell them, like, even if we do have to call CFS, if we're worried, we will talk to the ladies. We'll be like, this is really concerning. We do have to report for these reasons. Would you like to be involved in this? Like, we don't want to do anything behind your back. We want you to be a part of everything that we're doing on your behalf, basically, and really planning with women first. Again, like if we have these concerns, these are our concerns. What do you need in order to address these concerns, instead of right away calling CFS or calling the police or whatever that might look like, and just trying to put those front end services in first, like that preventive model, instead of always being reactive right away. It's kind of a difficult thing that's not going to get fixed overnight, but those are definitely some of the things that we see make a difference, where they're trusting us, where they're not necessarily trusting other places. I would also say that culturally grounded care is really important. A lot of places are like, I just don't trust like these colonial systems, like healthcare, whatever. Whereas you guys are culturally grounded, you understand what life is like for me as an Indigenous person, so I have more trust for you.
Thank you very much. Good response. I really happy of that. Thanks. Yeah.
In the trauma-informed literature, they also talk about another aspect of trust being about predictability, about really explaining what may be involved in the interaction and then living up to it, and not overloading people with the 20,000 things that could possibly happen, but starting in a way that is very clear and safe from that point of view, that it's structured and you're doing what you'd say you want to do as well. So it's a third piece, I think, to the two pieces that Hayley mentioned, that is really often noted in the literature, that is reparative of people who've been overwhelmed by experiences that they were powerless in. This is a situation where you can build that sense of security and safety by being clear and predictable and kind. And I think that's another aspect of trust.
I just want to add one more thing to this, multi-layered piece on trust, coming from the perspective of overall the co-creating evidence findings. And that is also starting from a place of addressing social determinants of health and the women's basic needs. So for many of the programs, all of the programs provided supports related to basic needs: food, nutrition, food security, transportation, clothing donations, all of that kind of, diapers, etc. And with that was often kind of an entry point for women to have some immediate issue addressed. And through that, there's the development of a relationship with one or more of the staff. And then through that relationship, and as Hayley's saying, you know, for programs that also had a culturally grounded approach or had Indigenous staff, if they were Indigenous clients, there is also that comfort and, you know, a building of trust. And for many of the programs, if they're also not able to offer a service or an activity on site, program staff could either accompany them to something in the community, or at least, again, through the trusting relationships that the staff had with other service providers, they were then a known entity. Talk to so-and-so, she gets it, right? So it's that relationship approach at both the client and at the service provider level that all reinforces the trust.
Thank you so much. Yeah.
Thank you. That was great answers. I noticed, Deborah, you responded in the chat to a question regarding the community of practice. In case anybody missed that comment in the chat, do you mind explaining?
Absolutely. So we've been really fortunate to have continued funding until next year, end of next year, from the Public Health Agency of Canada for what we're calling phase 2 of the Co-Creating Evidence Project. So we're not actively continuing to do the evaluation per se, but we have continued to stay connected with all of the programs, and part of that is through having a bi-monthly community of practice. However, it's extended beyond the 8 programs that were involved. It now is open basically to anyone who thinks this might be of interest, whether you are, you know, involved in some sort of, you know, multi-service or wraparound program, or you're interested in that, or you're interested in you know, and working in government service delivery, or not even service delivery. So they do, the topics have been kind of evolving and a little bit of a just as interests take us to different places. We meet we meet virtually the first Tuesday of every other month, 9 to 10 Pacific time. So I'm not gonna, you know, I could say 12 to 1 Manitoba time, but I know some people on this at this gathering today might be even something else. So if you're interested, I did put my email in the chat, or Ken, you can please feel free to share my email with anybody who'd be like to jump in and join us.
Absolutely, yeah, we can share that with the group. Thank you. Just looking at the time, we have about 7 more minutes. So were there any other questions from other people?
So can I see one more question from Melanie? And the question is, can the presenters talk more about the virtual community of practice that came out of the Co-Creating Evidence Project?
Yeah, that was the question I just
Sorry.
asked, Deborah. Yeah, no, that's okay.
Hey.
No worries. Any other thoughts or any questions from other people?
I was just thinking, Ken, you know, about the woman who mentioned her her work on the Saskatchewan border. And I just, you know, Deb and I've been researching programs for many years now, and not only in the Co-Creating Evidence Project. And one of the things we've seen is that, you know, not everybody is going to have the critical mass of clients like Shiwei has or Hayley has in Winnipeg, because they're in big cities. But they're still able to enact a wraparound kind of model, regardless of whether they're big or small. And, you know, I think it was interesting, the New Glasgow program is, New Glasgow is a very tiny place, right? But they were still able to think through about how, A, they bring the principles in, but also that they collaborate with others who are delivering the other services. So even if you're not like Mount Carmel, where your doctor's in the clinic with you, there may be ways of building a perinatal services network in your community that brings that one-stop idea to your community, even if you know it's not a co-located thing and you don't have hundreds of service users. So it's reinforce that idea that you can do one stop that's one stop by being a network of services rather than, you know, having them all co-located. And I just really want to honor the many communities who've thought through how to build those partnerships so that in effect, there's a kind of a mothering project in their community, even if they haven't been able to, you know, even if they don't have huge numbers that justify a big co-located service.
Thank you, Nancy. You read my mind. That was actually going to be a follow-up question, recognizing we know Winnipeg has a large center in Manitoba, but we have lots of other smaller communities with some really great networks, great coalitions. So I was going to ask, get any advice on that for the group.
Yeah, and I think, you know, just going back to Deb's, if you get Deb's slide deck with, you know, the kinds of things that women said were important and what they achieved and the theory of change slide, etc., it really is inspiring then maybe to talk about with their networks about, you know, are we doing this in many ways here, and what's the stretch for us? Are there other things, given what the Co-Creating Evidence Project learned, that we could enhance? Because I know that, like I said at the end of mine, that people are already doing so many good things, and it's just pulling more of that in and really not feeling burdened by doing more, but by just recognizing that these principles can really help guide our practice. Yeah.
Thank you. I think we have time for one more question before we wrap up. Okay, so we have a comment here saying that I agree, in Northern Saskatchewan, they are working at having family resource centers. They have one in L'Orange and one in Sandy Bay. In Creighton, we connect at interagency meetings, and we have made really good relationships with housing in our community and ICFS.
Brilliant, Shelley. And I know about that L'Orange work because I've been connected to some people, but great to hear that it's happening in Sandy Bay and other places as well. I used to live in Saskatchewan and travel up both sides of the north, and really miss visits to L'Orange and Sandy Bay. And it's even nice to see the names appear. And I know that good work is really going on. And maybe while I'm thinking about that, I'll just show my picture of birch bark biting that I got at one point in when I was in L'Orange. Just such an amazing Indigenous skill or craft, or I'm not sure what you would call it, but just an amazing thing that I think is so inspiring, the patterns that can be made through that kind of work. So yay, L'Orange.
Okay, well, thank you, everyone. We will have some follow-up pieces. We will have, I guess, the PowerPoint slides. We'll share Deborah's email, and anything else that came up in the chat, we'll make sure to share that with everybody after the session. The other thing that we want to make sure that we share with everybody after the meeting is the evaluation. You'll get an email separately on the evaluation for this session. It helps us get a sense of how sessions go, but there's also a piece at the end that allows you to provide thoughts, ideas on future sessions. And that really comes in handy for our planning committee. When we meet in June and over the summer, that helps us plan our series for the following year and gives us ideas on what are topics of interest. And from there, we try and think of different presenters that could help us deliver those sessions. So with that, I want to thank Deborah, I want to thank Nancy and Hayley, and I want to thank everybody for attending. Our next session will be on January 28th in the new year. That session will be, it's titled How to Talk to Children, Youth, and Young Adults About Their Diagnosis of FASD. So stay tuned. We'll have a poster coming out for that one in the near future. Thank you, everyone.
Bye for now.
Bye.